Good afternoon, everyone. My name is Elizabeth Mugi. I want to take this opportunity to invite you and to welcome you to our today's another exciting nursing series session. Today, we'll be tackling or we'll be handling on assessment and management of lower leg ulcers. Our presenter today is our very own. This is not his first presentation. He has presented severally with his passion and interest in wound care. He's Cyrus Ringera. He's a clinical specialist, wound and ostomy management here at Kenyatta National Hospital. He is well known for having pioneered the start of the establishment of our wound care clinic, that is at clinic number 24, that started as a small unit, but now it is fully operational with numbers of patients going high. He also acknowledges that most of our patients we are seeing at the clinic, 90%, like he'll be telling us, are coming with lower leg ulcers. And many instances, they're even coming with bilateral lower leg ulcers. And even some of them include our own, we nurses, doctors, we the healthcare providers. And therefore, he'll be taking us through, we need to know the assessment, how to manage them. And also, he will also be able to tell us whether we are a risk population for developing such a leg ulcers. So remember, this is it's a CPD accredited webinar. At the end of the day, we'll get our CPD point from the nursing standard department. Our CPD coordinator, Franklin, is in the office waiting to disseminate the CPD points once we are done. Again, as we continue with the nursing series, coordinated by the nursing standard department, we are still calling more. If you have an exciting presentation like these ones that we are going to have today, liaise with us, liaise with our research department, Tim Nelson and the others are there. They will help you to organize for a nice presentation. So without much ado, let's now invite our presenter, Cyrus Ringera. Cyrus, welcome so much and take us through this exciting topic.
Thank you much for that. Okay, friends, thank you for the opportunity. We are late by 10 minutes, but I want to believe that we'll be able to finish this topic today. Yeah, now this is one of the topics of interest when it comes to wound assessment and management. I'm a wound care expert at the Kenyatta National Hospital, but also I'm a trainer in wound and ostomy management in the same facility. Yeah, so we have a training that we started in 2018, and up to now we have been able to train many nurses from East Africa. Yeah, so the fees are affordable, and we want to welcome anyone of you guys who has feel that you have a passion in wound management, you have a passion in ostomy management. Come and let's train you. It's only 3 months. You don't need to go to South Africa. You don't need to go to Australia or any other country. It is right here with us in this country. We are privileged to be the first institution to start this training in East Africa. And we are welcoming all of you guys who have interest in this come and train. So we have seen these kind of patients coming to us. And if you have not seen this kind of a patient, possibly you will see with wounds on the lower leg, which are not healing. Okay, so these are wounds which have demonstrated signs of chronicity. You have given them your dressing materials. You have maybe done a few things for the patient, but they keep coming back. And this is what we're going to discuss today. What is this problem, and how do we help these kind of patients in our community? Now, here in KNH, we have a specialized wound care clinic at our surgical outpatient clinic, and we are seeing so many. Actually, the numbers are now a concern to us, and possibly somebody should take up this research and find out why is it that we have so many. Even most of them are young people. We actually thought that this is a disease that affects the elderly, but we are seeing this disease in very young people, 20 years, 25 years, and some of them are coming with the bilateral wounds on the lower leg, and this is a concern that possibly most of them, of course, are referrals from other counties, from the rest of the counties in our country. And I found it important for us to discuss this topic so that then wherever you are, you're able to be able to know how to possibly manage this disease. So very quickly, these are chronic conditions, okay? Now in the US, I don't know about here, but there's some statistics from the US which shows that almost 7 million are affected, and the cost for managing these patients is staggering. It's about $25 million, which is quite high. Yeah. So I don't know about our country, Kenya here. Uh, Possibly the numbers are even higher because I don't think there's someone who has done any research to that effect to be able to give us the numbers. But we know that in this country, most of our citizens are afflicted by this disease. Yeah, yeah. So these are chronic ulcers that are thought to affect around 0.8%, 1.3% of the adult population, and the cost of treating chronic wounds is quite high. Now, on individual levels, these are some of the wounds that actually drain the individuals for their finances. Yeah, yeah, because if somebody, most of the patients who are coming to us are reporting having wounds for 6 years, 12 years, some even for almost 15 years without any healing. Yeah, so these are alarming statistics that reflect a major threat to our public health in the financial system. And most of the wounds are actually chronic in nature, and they generally affect the quality of life of these individuals. They drain their money. They also drain us as healthcare service providers. Yeah, you see, nobody wants to see a patient coming back all the time with the same problem for 6 years. Yeah, so these are conditions that, of course, will give us burnout even when we're working for these patients. We want to see patients coming to us and eventually getting good closure. Yeah. So what we need to know is that we need to do a very good assessments on those patients, do a holistic approach in your assessment. Do not look at the wound only, but look at the whole person and determine the etiologic factors that are causing these problems, and then coin the treatment modalities in order to address the pathologic issues that the patient has come with. Yeah. So let's define what a leg ulcer is. Yeah. So these are chronic wounds, okay, as I've just said. Now, these are chronic wounds that usually affect, that go into the dermis with underlying etiologies of either a venous etiology, where a chronic venous insufficiency is involved, or arterial problems involving the arteries and the arterioles, or a mixture of venous and arterial problems. So a patient can come with a mixture of both etiologies, and these are very difficult to make a diagnosis on. Yeah, the rest of the group of the patients that possibly present are those with the neuropathic issues, the diabetic patient who usually develop these wounds due to, of course, neuropathic problems, and others who come with what we call, sorry, they come with what we call neuroischemic ulcers. And these are diabetic patients who have an accompanying arterial disease. Yeah, so we have several types of ulcers. We either your patient will come with a venous problem or an arterial problem or a mixture of the two, as we have just said, and or an ischemic or neuropathic condition. Yeah, so several etiologies which we deal with here is either a patient will come with a vascular etiology, of course, touching on the vein or the artery, or lymphatic problems that are usually contribute a lot to those patients who come with what we call a typical etiologies, which are very difficult to manage as well, and the hematological issues like anemia and sickle cell anemia. Yeah, so the lymphatic disorders and the hematological problems that we usually see in clinical practice contribute much to the patients who usually present with their typical ulcers, whose etiology is not very well understood. Yeah, so let's look at the arterial ulcers, and in this presentation we'll be dealing with the with the vascular issues. Yeah, so arterial ulcers are usually caused by either arterial insufficiency, and they are mostly caused by lower extremity arterial disease that affects the lower leg arteries. Yeah, so the other name, of course, for this is what we call lower extremity arterial disease, that is abbreviated LEAD, which is also known as peripheral arterial occlusive disease. So if you see some of the complex results coming with peripheral arterial occlusive disease, it's actually the same problem. So they are prevalent in patients with ischemic ulcers, especially among the elderly. Yeah, so this disease usually hits hard on the elderly and the young population, especially for the young people who who smoke, they use tobacco, or they have diabetes as a morbidity. Yeah, so it is good to appreciate that this is one of the leading causes of morbidity, that of course affects a very high number of people worldwide, almost around 200, over 200 million. And many individuals who suffer from this disease suffer from what we call the silent disease. They are not diagnosed early enough. Yeah, so the disease is usually asymptomatic until it progresses to very advanced levels where now the patient is almost losing their limbs. Yeah, so it is also important to note here that LED may not be the most common cause of lower extremity wounds, but its presence complicates the healing of some of these wounds because of partition problems and the other issues that we'll discuss later. Yeah, so let's also note that the wounds caused by the disease can actually be limb threatening. Yeah, so most of the patients actually will end up losing some of their limbs due to the progression of the disease. Yeah. So critical limb ischemia is the term which we usually use to describe the advanced levels of the disease. And it is the classical indicators for this for this is the patient may possibly complain of rest pain, and the patient may complain of ulcerations, a bit of ulcerations on the lower leg. You may actually notice a bit of gangrene, including your normal routine examination, and an ankle bronchial pressure index of between of 0.9 or less. I'll discuss what that one is in this study. Yeah. Yeah, so don't worry, just hold your peace. I will discuss what is ankle bronchial pressure index in this study. Yeah, so the goals of management for this patient, of course, will include healing of the ulcers. Okay, so your ability to be able to monitor the presentation of the ulcers and what to apply on those wounds really matters. Limb preservation, we don't want patients, of course, losing their limbs, and managing pain because some of them come with very severe pain, and of course, improving the quality of life of these individuals. On the other hand, venous ulcers are usually a result of valvular insufficiency and increased venous pressure. And we'll see what that one is. So there is usually the patient presents with either valvular insufficiency or increased venous pressure. A bit of edema is very common for these patients because of the increased permeability of the capillaries. And the causes are lower extremity venous disease, which is abbreviated LEVD. And the other name, of course, is known as venous insufficiency. And this usually covers a full spectrum of pathologic and functional abnormalities of the venous system. Yeah, so patients who have this disease usually come with different levels of severity. So the severity range from edema, complicated telangiectasis, what we call spider veins, and this can actually be observed around the calf muscle area, to more complex conditions like skin changes. which are very common with the venous patient. They usually come with venous eczema, they come with what we call hemosiderin staining. And I'll show you some of the slides that have these images, and also ulcerations, or what we call venous leg ulcers at the lower leg. Yeah, so it is also important to note that varicose veins are present in most of those patients. Yeah, so when you palpate the calf area, you actually even feel some of them, and the disease affects more females than males. Yeah, the disease most of the patients that will present with the disease, the higher population is the female patient. Yeah, now the pathology of these venous ulcerations involves several things here. And we are going to briefly discuss the normal physiology and what happens in the vasculature here. So the normal functioning of the venous system, of course, we know is dependent on the patterns of the veins and the condition of the one-way valves in the perforators and the muscle pumps in the foot and the calf. Okay, that is what usually happens. And it's very important for us to understand this so that then, of course, we know what happens when the pathology sets in. So normally, blood is drained from the superficial vessels of the skin and the subcutaneous fat by three major vascular pathways. So we have the superficial veins, we have the deep veins, and we have what we call the perforating veins. So that is normal physiology, and I'm sure all of us remember that. Yeah, so the superficial veins are located above the deep muscular fascia, and they include the great and the small saphenous. This is just for reminders. And the deep veins lie within the muscle compartments or between the muscles. What we call they're either intra or intermuscular, and the latter are more critical in the development of the disease since they are exposed to very high levels of superficial pressures during calf muscle contraction. The perforators, also known as the communicating veins, are the ones that are responsible to connect the two systems. So they pass through the deep fascia at the mid-thigh, the knee, and the ankle, and it is estimated that there are at least 90 of these in each leg. Yeah, so they're equipped with the direction of bicuspid valves that open to permit blood to permit blood flow out of the legs towards the heart, and then close to prevent back. Okay, that is in the normal physiology. And the calf muscle pump and the valves normally work in concert. They work in harmony with each other to promote the return of blood against gravity to the heart. So what happens is that when the calf muscle is relaxed, the valves open, and then they allow the blood to fill the deep veins, and the filling increases the pressure in the deep venous system, and the contraction of the calf muscle then, of course, empties the veins, thus reducing the venous pressure. But what happens now with the LEVD is that now pathology will actually set in when there are abnormalities in any part of the system that result in impaired venous return and persistent high pressures within the deep venous system. And that is what we usually call venous hypertension. It's very important to know that, or to internalize that. So it's caused by either obstruction, like in cases of deep venous thrombosis or DVT, that usually reduces the venous return and results in valvular dysfunction. So DVT is quite damaging. Yeah, so venous hypertension is the etiologic factor common to the development of this disease. It occurs in the venous system, does not empty, causing capillary bed congestion or engorgement and leakages. And that is why most of these patients come with edema. Most of the patients that will present to you with with the venous ulcerations and the lower extremely venous disease will come with accompanying edema. That is one of the things that symptoms that possibly you are going to observe. So this later causes pathologic changes in the superficial venous system and the microvascularity system, and you notice this even when you examine the patient, And due to high venous pressures within the superficial veins, then damage to the skin later results. And these patients will come with a condition that resembles dermatitis. They'll come with very, very scaly lower leg. They'll come with tissue fibrosis. And some of them who of course, have most of those who come with ulcerations are those who have stayed with the disease for quite a long, long time. Yeah, so the pathology or the pathologic mechanisms of ulcerations is not very well understood. It's still under study. But there are several theories that actually some of the scholars have come up with, and some of them actually attribute that to damage to the epithelial lining of the vessels. Others attribute the problem to abnormal levels of inflammatory cytokines like matrix metalloproteases, which of course contribute to the development of wound chronicity. Yeah, so most of the chronic wounds will display very, very high levels of MMPs, and that is why sometimes we use some of the dressings that we call matrix modulating dressings to be able to address this problem. Other scholars have attributed these conditions to comorbid conditions like obesity and genetic factors. So it is a topic, or it is an area of study which is still being studied by most of the scholars. Yeah, so when you're doing assessment for patients with the lower extremity venous disease, do a good history, okay? Yeah, so make sure that you find out what is causing the disease and what contributing factors are there to which of course contribute to valvular or calf muscle pump dysfunction. Yeah, ask about the history of prior leg ulcerations, because some of these patients will come with old scars. They'll tell you, I had a wound here, it healed, this one healed last year. So when you observe the patient's leg, you'll notice several areas with old scars, and that's a very suspicious leg for a venous disease. Find out about previous treatments, how as the patient has any history of striping of varicose veins, any surgical procedures which have been done, any family history of arterial or venous disease, because some of these also go in their family histories. Most of the patients have, they tell you that my dad had this, my uncle had that. Yeah, so find out, do a comprehensive history, assess also for factors that contribute to valvular compromise, like conditions that increase the resistance to venous return, like obesity. A high BMI is a risk factor here. Or those patients who have multiple pregnancies, yeah, the female patient who has multiple pregnancies, assess for conditions that directly damage the valves, like deep venous thrombosis, as we have just mentioned, assess for conditions associated with a diagnosed DVT and pulmonary embolism, like leg trauma, like history of leg surgery, or history of head injuries, and other inflammatory autoimmune diseases also, which contribute to this problem, like systemic lupus, erythematosus, and phospholipid syndrome, which also contributes to microthrombi from venous inflammation. So all these conditions, just do a proper history, do a proper assessment, and determine what exactly the patient is presenting with. Yeah. Now, there are some conditions that of course will result to calf muscle pump dysfunction, like advanced age. So the aged have issues with that. A sedentary lifestyle or reduced mobility is another one, and of course occupation that requires long periods of sitting or standing. Now, like some of the drivers that drive long distance vehicles also belong to the risk group for this problem. Yes, yeah. So most of the patients who will come with this disease also will come with an history of how the disease started. So 74% of patients who come with conditions will give you an history of specific triggers Some will tell you that, I had a penetrating injury, and maybe I had an insect bite. Maybe some will tell you that I had a burn injury. Some will tell you that I had a bit of itching and I scratched my leg. So they'll give you an history of triggers. Somebody can stay with this disease for many months without actually knowing that they have, or even years. But one trigger will actually manifest very big ulcers. Yeah, so the initial presentation of this disease also varies widely, but the common symptoms that the patient will come with will include pain. They will tell you that they come with aching legs and a bit of edema. I think we have discussed how edema sets in. You come with very, very dry skin, very dry, scaly skin, and feelings of tightness or heaviness. And most of them will be they feel a bit of irritation, and they come with very, very itchy skin on the lower leg. Yeah, so most of them report pain, which is worse with prolonged dependency. And the pain, of course, improves with elevation. And some of them will verbalize that the pain is severe, uh, enough even to limit the ambulation, especially at night. Most of them, of course, will complain of very, very severe pain at night. And some of these patients will actually be fatigued because of insomnia. And actually, some of them have actually interacted with some of the patients who are even depressed because of long periods of pain which has not been relieved. Yeah, so another physical exam here is warranted. So we need to do a thorough examination of the lower extremities to include the skin integrity, find out whether the patient has peri-wound maceration, which is very common because most of them are mismanaged in some areas. Now, the venous leg or the venous patient, because of edema, will come with very, very exudative wounds. And if exudate is not very well managed, they will present with periwood skin maceration. And I've seen patients coming with very, very bad maceration, of course, which even affects the initial wound. And others will come with a lot of edema and ulcerations on multiple areas. So the common signs will appear in the gator region. It's very important for us to note that. So the gator region is the region above the ankle to below the knee. That's the common area that possibly you will see these problems. And when you do your examination, you find that the patient has dilated veins. Some of them will have a bit of varicosities, varicose veins, notice edema, you notice a bit of skin changes. And as we have just discussed, and you notice the skin will appear like it has a bit of dermatitis, and it's quite flaky. Yeah, very, very, very flaky indeed. We call that venous eczema. So the diabetic patient will come with a diabetic foot, of course, or diabetic ulcerations due to neuropathic issues because of loss of protective sensation. And the neuroischemic patient will come with an accompanying diabetes as a comorbidity. Of course, you will have diabetes and arterial disease. Yeah, so those are very difficult wounds to manage. We'll discuss their management quite soon. And the patient with a mixed etiology will have a combination of both arterial and venous disease. Okay, yeah, let me. Now, this table here is a very important table. I want us to go through it very, very fast. It has indicators for the assessment of venous and arterial leg ulcers. So the first column is a column of predisposing factors. So the factors that predispose a patient to arterial disease, as we have just discussed, is like arteriosclerosis, advanced age, diabetes, hypertension, and smoking. And the factors that predispose a patient to a venous disease are like history of deep venous thrombosis, valvular incompetence in the perforating veins, as we have just discussed, and obesity. So this table actually summarizes most of what we have just discussed. And the associated changes in the leg for the arterial patient, you notice thin, shiny, dry skin. You notice wicked nails when you do your examination. You will notice absence of hair growth, including on the female leg. Okay? Yeah, we know, of course, females have a bit of hair also, although it may not be as pronounced as for the male patient, but you find that there's a complete absence of hair growth even for the female patient. You may observe pallor on elevation of the limb, and when you touch the limb, it will be cool. It will not. It will be a bit cool. Okay. Whereas for the venous leg, you'll find there's a bit of edema, which is not on the patient who comes with an arterial leg. Okay, there will be a bit of reddish blood pigmentation that we call hemosideral staining. There will be evidence of healed ulcers. So you find that there are scars here and there on the venous patient. You will find dilated and tortuous superficial veins even on palpation, and the limb may be warm. Notice the difference between the two. Yeah. Now, the ulcer location for our arterial patient may be between the toes or the tip of the toes. You may find them over phalangeal heads and above the lateral malleolus. Whereas when you are dealing with the venous patient, you may find them generally on the lower third of the leg. Now, when you look at the wound itself, the ulcer characteristic for the arterial patient, you may find that you may find that when you observe or when you assess the ulcer, it will have very well demarcated edges, almost patched out edges, very well defined edges. Okay, it could be undermining, of course, and you will find black or necrotic tissue at the wound base. And when you look at the wound base, generally you will observe a deep, pale wound bed. Okay, but the patient who comes with a venous ulcer will not have well demarcated edges. You will find very uneven edges. Sometimes it is very difficult to tell where the edge of the wound is for this kind of patients. Usually they may have very good granulation, which is not healing. And it is very, very hard to observe any necrotic tissue or any slough tissue, not unless the patient has come to you with very heavy infection. If the patient comes with very heavily infected wound, of course, you may find a bit of non-viable tissue at the wound bed. But generally, these patients will present with very good granulation, which, of course, is chronically inflamed wound bed, which is not advancing towards healing. So the pain associated with these patients are usually extremely painful for the arterial disease. So the patient will verbalize very, very severe pain, whereas for the venous disease, you find that the patient, in a scale of maybe 1 to 10, they verbalize maybe a pain or a score of around 7 or 6 or 7. All right. Now, the arterial patient may complain of pain at rest, which is relieved by lowering the leg to a dependent position, whereas the venous patient may complain of discomfort, which is relieved by elevation of the leg, which is the opposite of the other. Okay, yeah. So those patients who come with arterial disease may have diminished pedal pulses when you do your when you sound them, but the pedal pulses for the patient who comes to you with a venous disease may actually be normal. Yeah, it's very, very important to note that. Now, the arterial patient may also come with neuropathy, especially if they have diabetes as a comorbid problem, whereas the patient who comes to you with a venous disease may come with leaking edema and, of course, a bit of maceration, because these are very productive wounds, as I've just mentioned. And of course, some of them will come with pruritus and a lot of scaling on the lower leg. So this is a very, very important table that I wanted us at least to appreciate those indicators, so that then, of course, when the patient comes to you, you're able to make to distinguish between the arterial and the venous problem. Yeah, so this is a classical appearance of an arterial leg. You can see a bit of quite thin and shiny, no hair. There's completely devoid of any hair. A lot of hair loss on the lower leg, and the appearance of the ulcer for those patients are usually very well demarcated edges, punched out edges, deep pale wood bases, and some of them will actually present with necrotic or sloughy wood bases. The venous patient will come with wounds of generally on the lower that of the leg, and when you observe some of those wounds, they will look very well granulated. Some of them will have uneven edges and very shallow ulcers. Now you realize that the arterial ulcers are quite deep with pale wood bases, but the ulcers associated with venous disease may have a bit of granulation. They could be shallow, and when you observe the periwood area, it could have a bit of maceration. Okay, so this is how venous ulcers actually appear. You can see the edges are not even, you can't even tell where the edges are. There's a lot of staining that is, you can see that around the edges that we call hemosideral staining. There's a lot of edema, and many times the patient will come with periwood maceration because of poor exudate management. Yeah, so we need to choose our exudate management dressings well. Uh, Now, CAP classification of venous disease is it's just like the way we classify breast cancer, because in breast cancer we use the TNM classification. So the CAP classification was initiated by the American Venous Forum, which created a system classifying the disease, and it was perfected in 2004, and it retained the basic CAP categories, uh, namely C standing for clinical, E standing for etiological, and A standing for anatomical, and P standing for pathophysiological. Yeah, so it's a way of classifying the disease. And from this table, we can see from C to C6, C meaning no, these are patients who come with no signs of venous disease. C1 showing a bit of telangiectasis, C2 showing varicose veins, and C3 showing presence of edema. C4 demonstrating skin changes due to venous disease, and C4A showing pigmentation and or scaling or dermatitis, venous dermatitis. C4B showing atrophy blanchi, and C45 showing evidence of healed ulcers. C6 is a patient who comes with active venous ulcerations. So it's very important to note that the term chronic venous insufficiency is reserved for those patients who score between C4 to C6. Okay, let's note that. We cannot properly call or use the term chronic venous insufficiency for any patient who has not attained that score. Yeah, so for your patients, of course, observe the location of the ulcer, the color of the ulcer. Make sure that you feel whether the patient has the limb is warm or not, because we said for the venous disease, you may expect a bit of warmth, But for patients who come with arterial disease, actually, the lib will be called. Do you observe for presence of hair, a capillary refill? Do your pedal pulses, determine whether they are there or not, and check the condition of the nails. Yeah, the pedal pulses will be diminished for the arterial patient, but they could be normal for the venous patient. That's an repetition and this for emphasis. Yeah, so the pedal pulses, we are interested in the dorsalis pedis, we are interested in the peroneal, in the posterior tibial area. So let's solve these pulses. For us to be able to do an ankle bronchial pressure index as well, we need to be able to know where these pedal pulses are. Yeah. Now, when we are doing ankle bronchial pressure indexes, if you can be able to get an ultrasound machine like the one that you can see in this slide, that's fine. But if you cannot, just use your fingers, because we do our normal blood pressures and we use our fingers to be able to determine where the our pulses are. So just sound your pulses. Um, Ask the patient to lie down at least 20 to 30 minutes before you can start your procedure. Sound your pulses, okay, and then take you just use your normal blood pressure curve. uh, do your BPs on both hands and place your ankle your BP curve around the ankle of the patient, and do the same on both legs, and then determine the highest readings for both arms and both feet, and that is how we actually do our ABPI. So you calculate the ankle bronchial pressure index by dividing the highest ankle reading in each foot by the highest bronchial reading, and that is how we determine what the ABPI is. So, for instance, if your ankle systolic pressure, and actually what you're doing as systolic pressure, sorry about that, I should have mentioned that a bit earlier. So, if your ankle systolic pressure was 110 and your bronchial systolic pressure was 120, then, of course, with ABPI, divide the two, you get 2.92 millimeters of mercury. That is what ABP would read like. So the normal ABPI readings the number should be 1. Sufficient flow should be 0.8 to 1. 0.5 to 1 reading will show a presence of disease. And ischemic ABPI would read less than 0.5. Okay, and calcified arteries or veins will read above 1.2. Yeah, so unless clinical science suggests otherwise, a 0.8 to 1.2 reading is considered by most specialty centers a safe range to apply compression bandaging systems. We will discuss compression bandaging in a short while. And that is only applied to manage venous insufficiency. We do not apply a compression bandaging system for patients who come with venous disease, arterial disease. An ABPI of 0.5 to 0.8 indicates a mixture of the two etiologies, and any ABPI less than 0.5 is indicative of ischemia, and compression therapy in these patients is contraindicated. Any reading above 1.2, and some centers will accept 1.3, may indicate calcified arteries. And if you find that kind of a reading, then you can proceed further and do a toe bronchial pressure index. Okay, so we'll also see what that one is shortly. Yeah, so a toe bronchial pressure index is an invasive test which measures the arterial perfusion in the toes and the feet of the patient with incompressible arteries due to calcification. And that's the patient who you have done ABPI and you have found that it is above 1.2. Okay, so it's common in patients with diabetes. Okay, those patients with renal disease, or those with an ABPI of greater than 1.3. Of course, some centers will accept 1.2 to 1.4. Yeah, so remember, these two arteries are less affected by calcification and incompressibility than the ankle arteries, and they provide a more accurate diagnosis in the presence of calcification. Yeah, so a normal toe bronchial pressure index will differ from a normal ankle bronchial pressure index because the blood pressure in the iliacs or the great toe, if the patient has one, because we have seen most of the diabetic patients coming with some the iliacs missing, is expected to be at least 30 millimeters of mercury less than at the ankle or arm. Yeah, so if you find that you are getting very high readings when you do your ABPI, then proceed to do a TBPI, which of course will give you very, very, very good conclusive readings as whether if whether can save that patient's limb or not. Yeah, so the normal range of TBPI is considered to be an index of above 0.65 to 0.7, although variances may exist between some different specialty centers. Yeah, so if the top bronchial pressure index is below 0.65, if it is below that, then of course there's reduced blood flow to the small vessels in the big toe, and saving that patient's foot may not be possible. Now, do your investigations for your patient who comes with lower leg ulcers. Do your Doppler ultrasound. Of course, that ultrasound is non-invasive, and of course, it will give you very, very good results as to whether the patient has uh, a venous problem or not. But also do your blood pathology, do your HBs, do your liver function test to determine the parameters for your serum albumin. Remember, the body heals, most of the wounds heal through proteins, and if we have low parameters, then of course you need to optimize that. Do your angiographies, do your venographies, do your biopsies. Every chronic wound, listen, every chronic wound requires a biopsy because nowadays we are seeing malignant changes in most of the wounds that we are seeing today. And I want you to say this, if you do not give your acute wound optimal wound management, you may most probably end up with a chronic wound, okay? And if you do not address the needs of that patient and the wound and the chronic wound, if you give some optimal care, you may most probably end up with a malignant wound. And we are seeing many Magellan's ulcers, which are malignancies that have been treated by some of us in our clinical setting. So we have to be very careful about that. Yeah, so quickly, let's go to management because of time and look at having that background. We cannot discuss now how do we manage these patients. Yeah, yeah. So one, our aims here, our aims of management is to identify and treat the precipitating causes of these problems. Of course, we also need to promote circulation and improve venous return, and that is done uh, that is done by doing appropriate compression bandaging. We need to promote healing by using appropriate wound care solutions for cleaning and ideal primary and secondary dressing materials for our patients. And of course, we need to promote preventive care. Like for most patients who come with neuropathic problems, flooding is one of them. Yeah, so the general advice for the patient is daily inspection of the legs and the feet, maintenance of skin hygiene, make sure that they maintain good hygiene, they moisturize. Now, let me talk about moisturizing. Okay. Let's not use Aramis. Okay. Let's not use Aramis as our moisturizers for the patient with the lower leg ulcer. And let's not use Vaseline as a moisturizer. Now, you can try this because if you apply Vaseline on your leg and you go out there, it will attract a lot of dust. Now, remember, this patient has a wound. Okay. So for if you are going to succeed to heal that wound, shy off from some of these products to keep dust on the patient foot and use an appropriate moisturizer. For those who smoke, remember what smoking does. It affects it affects the quality of uh, the ECM, what we call the extracellular matrix, where we get our granulation, and it brings a host of problems in the wound healing trajectory. Of course, nutrition and loss of weight is also very, very important, because we have seen what a high BMI does with regards to the development of the disease. Okay, ambulation is encouraged if the patient can tolerate, carb and muscle exercises, elevation of the feet when they're sitting, and they are encouraged to elevate above the heart level to be able to improve venous return, elevation of the foot of the bed, especially for those who have venous disease. Although it's a problem, it's a problem with most of the patients. Most of them are not willing to do that, but it is encouraged, because this, of course, improves venous return, avoiding constipation, which of course increases pressure and compromises perfusion, and compression bandages and stockings, which we are going to discuss shortly, and of course medication review, or referring this to a vascular specialist, where they are put on some treatment like Daflon and the rest. Yeah, so we will have a look at all that. So the patient who comes to you with an anterior leg will require a vascular specialist review. Please refer those patients, because there are several treatment options that can benefit them. Some of them, of course, can be taken through surgical sympathectomy for those who have small vessel disease, angioplasty, or bypass surgery. For those with large vessel disease, has also been seen to be very, very uh, to help these patients. And of course, some of them have ended up with amputation, uh, like for those who have very severe disease, which has, of course, progressed to very to later stages, where you may not be able to save the limb. Now, compression bandaging for the arterial patient is not encouraged, because compression bandages are not to be used on these patients, because they can further compromise arterial flow and cause many other problems. So let's not compress the arterial patient. Okay. So healing may not be our goal uh, for those who come with arterial leg ulcers. It may not be an option. But of course, it will depend on the severity of the arterial disease. That's one. And also whether we have good perfusion or not. Yeah, so the goals, of course, or management here will be pain management, which is usually quite severe, prevention of infection, and healing if tissue perfusion is adequate. Because some of them actually do heal. But those who heal are those who have good perfusion, that, of course, would encourage those wounds to eventually heal. Yeah, so for those who come with open wounds, the dressing options will depend on the initial assessment. And I think in this presentation, or maybe in other presentations, I don't know whether we have done any presentation on wood assessment. I think we have done one. Yeah. So I don't know if you can remember what we did in wood assessment. It is very, very key to be able to know how to carry out a good wood assessment, so that then, of course, you know the needs of the patient and the wood they have brought you, or they have come with. Nowadays, we don't look at the wood; we look at the whole person. Yes, but if uh, you are faced with this situation, of course, you have to remember how these ulcers appear. Remember, they are quite deep ulcers, and they have very pale wood bases. Some of them will come with necrotic tissue, which may warrant debridement. Yeah, so you may need to choose whether you do a biosurgical debridement, or whether you do an autolytic debridement, or you do an enzymatic development using enzymes, which is depending on whether the patient can afford that or not, or possibly can even do a surgical development if the patient has the financial support that they need, because surgical development is quite expensive. Yeah, so the dressing choices would range between antimicrobial foam dressings to silicone dressings for those with fragile skin, and other moisture donating dressings like the gelling fibers and calcium arginate dressings. Those patients who come with venous leg ulcers, sorry, um, the treatment of choice is graduated compression therapy. Okay, now that will apply if you have done your ABPI, ankle blood pressure index, and determined that the patient qualifies for this procedure. Remember, compression therapy is very expensive. Actually, one kit nowadays is going for almost 3,000 shillings. The patient will be put on one kit possibly per week. And we don't want to exposing these patients to this kind of management, very expensive management, without first determining whether they need this management or not. Yeah, so the pressure, the target the pressure is between 30 to 40 applied at the ankle and reducing by 50% below 2 fingers, below the knee. Okay, so the aims of compression therapy for the venous patient is one, to improve the calf muscle pump function. Okay, two, to improve the venous return. And of course, with that, then of course, we manage the edema as well. We control the edema and we facilitate the healing of the wound. And of course, the other is to reduce venous hypertension. Yeah, so graduated compression results when applying a bandage at a steady and even pressure. And this is learned over time. You have to master that you have to have that dexterity of how to do it, because I've seen patients if you do not apply this bandage the right way, you may possibly cause damage to the patient's limb. You have seen patients who present with bottle-shaped legs because of very, very tight compression, and it's usually quite painful. And some of our patients will actually keep quiet and not tell you.
Apologies to our participants. We are facing a bit of a technical hitch from our end. We are trying to sort it out in the next few minutes. Can you stay online with us as we work on it? Thank you.
Hello, our members. Hope you are still holding on as we try to fix our internet back. Our technical team are both working on it. But meanwhile, to our presenter, Lingera, thank you so much for this presentation. We are looking forward to a good ending and understand everything about it. But there's a question that we can be responding to. Like, why is smoking a predisposing factor in the arterial ulcers? That's our participant, Robert, asking.
Robert, because smoking, um, if you have read on some of the packets that are sold, the government has actually forced the manufacturers to write the dangers of smoking on some of the cigarette packets. One of them is actually damage the blood vessels. Okay, so it's one of the major causes of the sclerosis and other problems that usually lead to compromised perfusion.
Oh, all right. Thank you, Robert. I hope you answered. Silas, there was also another question. Why are women more at risk of leg ulcers compared to our counterparts?
Yeah, that's a very good question. Yeah, I hope you can hear me. Yeah, so one of the reasons is because of issues that concern parity. Now, those women who have multiple pregnancies, or those because of the trauma that women usually go through pregnancy, because pregnancy usually affects blood flow of pregnancy return. And actually causes most of the mothers to develop varicose veins. And that is what usually causes most of the women to later in life present with this disease. So I think we can go back to our presentation and possibly go with it, but because of time, so then we can be able to see whether we can finish. Yes. Sorry. So we have four classifications of compression bandages. Compression stocking. So we have class 1, which will give you between 20 to 30 millimeters of mercury of pressure. We have class 2, which will give you between 20 to 30, between 30 to 40, and class 3 that will give you between 40 to 50. Okay, and class 4, which gives very, very high pressures up to 60 millimeters of mercury pressure. So this is the class that we call very strong or pronounced deep effect products. Now, when you are setting your patients to buy these products, it is very important to set them for a certain class, depending on your assessment and what you have determined that your patient should wear. Don't just send a patient to the shops to buy a compression stocking without determining which one it is. Okay. Yeah, so that table shows the difference between the US and the UK classification because they differ. Because the US classification has class 1 up to class 4, but the UK classification has class 1, 2, and 3. So if you're dealing with some of these products from these countries, you will know which is a class 1 US classification and what describes a class 2 or class 3 of the UK classification. Yeah, so do not send your patients to buy compression stockings without first doing measurements and determining. People selling these products in town, some of them are not medical people, and they will just sell whatever they have. And of course, you may end up with many problems later. So taking measurements early in the day or following a period of rest, and take with the leg elevated in order to obtain measurements not influenced by dependent edema. Yeah, so the measurements should be taken with the person standing with the legs slightly apart or sitting with the knees at right angles and the foot flat on the floor. So to measure for below knee stockings, measure the ankle circumference, because there are different type of stockings. There are those which will go up to the knee. There are those which will go up to the thigh, and there are those which will go all the way like a trouser up to the waist. So to measure the ankle, to measure for below knee stockings, do a measurement. Measure the ankle circumference for centimeters below, sorry, above the malleolus. Then measure circumference of the calf at the widest point, and measure for length from just below the knee to the base of the heel. Okay, if you are prescribed a thigh length stocking, measure the circumference of the ankle 4 centimeters above the malleolus, do a circumference of the calf at the widest point, measure the circumference of the thigh at the widest point as well. And then you measure for the length from the gluteal crease all the way to the base of the heel. Okay. Yeah. So if you prescribe a full leg or waist stocking, or what you would do is that just repeat all what you have done for the other two, and of course include the waist as well, so that the patient gets the right size in summary, how to do our up to the waist level stocking, up to the thigh level stocking, and up to the below knee stocking. Yeah, so these measurements are very important if your patient will go for the right product. Now, we do not have not that we have pneumatic compression pumps in the country, but this is good to know that, of course, this is an alternative treatment to compression bandaging or stocking in preventing DVT and managing venous edema and also leaf edema. Leaf edema is a condition that, of course, this is a topic that can take weeks to teach. I usually take weeks to teach my patients, and possibly when I get time, I will come back with leaf edema as one of the topics. But these are pumps that almost resemble our negative pressure therapy systems, and they are indicated for patients who are intolerant of compression bandages, because not every patient can tolerate a compression kit, or for those with limited mobility, or those who cannot elevate their legs without difficulty. Yeah, so the therapy involves compression garments or sleeve which are attached to a pump, an electric pump, and the treatment can be applied either in an intermittent or sequential pattern. So the pump has settings where you can be able to set an intermittent therapy or a sequential therapy, just like the way we do set for negative pressure wound therapy. So the sequential compression garments have 3 or 4 individual chambers that inflate in sequence distally to proximally, followed by a resting deflation cycle. And the objective is a milking effect. A milking effect will enhance venous return in the leg. So the compression device is applied over the stressed paralyzed leg, and the therapy is usually given twice daily. So I don't know whether we have this kind of treatment in our country yet. Yeah, so it delivers very, very high pressures, up to 15 millimeters of mercury pressure. The circumferential measurements of the leg are recorded before commencement of therapy, and they are done at regular intervals to assess the progress. Yeah, so so this therapy, of course, cannot be given to clients who have arterial disease. You cannot give to those who have cellulitis or congestive heart failure, those with a very, very extensive leg trauma. Those are not indicated. The treatment is not indicated for this kind of patients. Yeah, so that table also will show you some guideline on who to compress and who not to compress. Of course, we do not compress arterial ulcers, but those patients who have an ABPI of 0.5 to 0.7, which of course gives us an idea of mixed arterial and venous etiology, and benefit from that. So if you can go through that table, or maybe take do a picture or photo of that and keep it. So then, of course, if you have a patient who has these kind of parameters, you know when to apply your compression and when not to apply. Yeah, so remember, when these patients come to you, a good skin hygiene is a must. Of course, clean their legs, and let's not clean with soap, because soap, most of the soaps that we are using, we don't know what chemicals the manufacturers have mixed, and these patients have very irritated skin, and I mean, we don't know. Some of the patients, of course, will react to some of the soaps that we are using. Okay. Remember your choice of dressing also to treat, to lower the bioburden and to treat the wound. Of course, depending on what you observe, you can either use medicated honey, you can use your silver dressings. Now remember, honey is not the honey we buy from the shops. It is not the honey from Kitui, even if it is original. It is medicated, and because of time, let me just mention that you can use some of the dressing choices like calcium arginates that will donate moisture, give you very good hemostatic benefit, and gelling fibers, and even foams, which are antimicrobial in nature. Especially if you're dealing with very, very active wounds, use super absorbents. Always apply the padding, which is the first layer of the compression if you are doing a compression for the venous patient. And remember what this is just a summary of what I've been talking about. Remember the different types of bandages that we have discussed: the 2-layer systems, the 3-layer system, the 4-layer systems, and how you can apply them. Remember which layer is supposed to be applied in spiral and which layer is supposed to be applied in a figure of 8. Now, the tubular bandages, of course, I mentioned that although we can use them as alternative dressings, we can also use them to give our patients some limited compression, and some of them are quite stretchy, and they will actually give you some limited compression, which is better than actually the one that can get from the stockings. Okay, yeah. So I think because of time, I will finish this presentation there. And maybe next time, possibly, we will have another session where we can discuss some of these topics. Now, there are some topics I've done on TikTok. I have an account. You can search Ringera Woods. It is not an entertainment account. It is only for those who want to learn wood management. You can actually search Ringera Woods and follow and see some of the lessons I've done there. Because what we are trying to do is to build capacity in these countries so that many of you guys are able to manage our healthcare-related problems and ostomy-related problems. So thank you so much for listening. It has been a pleasure having you guys around, and I believe next time we'll be able to talk more. Back to you, Mugi.
Wow. Thank you so much. Thank you so much, Ringera, for such a nice presentation. It's always good and pleasure to have you around. Just before you exit or before you leave, Isaac Cheng is asking, how useful are collagen pads?
Now, collagen, collagen is one of the very specialized dressings that we have around, very expensive as well. We may not use collagen for some of these chronic woods without first correcting the etiological problems first. Yeah, okay. We may not use collagen also for some of the dirty woods and some of the cavity woods that we are coming, that we are managing in our clinical settings. So let's reserve collagen for woods which have granulated. They do not have other etiological issues. And you see, some of the collagen dressings are biodegradable products which are meant to finish up the job. They almost, some of them actually resemble a skin graft. Yeah, so I've seen some of our nurses piling collagen, very expensive product on their trolleys and going for a startup dressing. And that has really caused a lot of problems. So you may actually overgranulate your woods and create very funny looking woods with collagen dressings if you're not very careful. But of course, we have other dressings which are very expensive, like the matrix modulating dressings like pomegranate, which also, of course, is meant to balance or modulate your matrix metalloprotesis, so that then your wood can progress towards the proliferative phase of wood healing. Now you need to understand the phases of wood healing here. If you have to use these dressings, okay? Yeah. So maybe you can. I don't know who has asked that question. I can give my number so that we can discuss that later, because there's a lot to discuss there. Okay, so possibly you can take my number. Maybe Mogi will give you my number, then you can call me later, because we may not discuss exhaustively about collagen in the limited minutes that are left here.
Wow, thank you, Ringera Woods. Ezra Kiprotich is asking, is there any chance of the wound healing completely?
Absolutely. Absolutely, Kiprotich. Okay. So if you have determined that your patient has a venous problem and your patient qualifies for compression bandaging, just do your compression bandaging and do your wound care, do your appropriate wound management for your patient. And I have managed so many patients with venous disease, lower leg ulcerations, and have actually healed completely. So yes, they will heal.
Wow, thank you. Joseph Wanjohi is asking, or has a comment, that we avoid iodine-based tests.
Okay. There is no problem with an iodine-based test, because the dressings that we are seeing in the market today are very well balanced to deliver safe iodine to the patient. And one of them is Inadine, which is marketed by Philips. Okay, so Inadine has 10% iodine with ethylene glycol, but I've used only 1% of the iodine to the patient, which is safe iodine. But the problem actually with iodine is with the 10% povidone iodine that we have in solution in our country, which is a cytotoxic agent. Now, there is, according to some of the scholars, It is allowed to use as a toxic agent, but on very limited days. Yeah, but it is not safe. When we say a product is not safe to use, we are not saying that you cannot use it. We are saying it's not safe. And I'll give an example. You can actually drive from here to maybe Vika with no safety belt, but it is not safe because if an accident happens, you'll be thrown out of the car, possibly you lose your life. Yeah, so the 10% pop iodine we have in the country is very, very toxic to fibroblasts because at 5% concentration, iodine has been noticed to actually cripple granulation. So there's no harm with iodine-based dressings, and usually those dressings are in the family of the antiseptic tube dressings, and they are actually available and they're quite cheap in the market.
Wow, thank
Yeah.
you. And if so, then can we use ordinary soap to clean the wound?
No, we cannot because soap is not sterile. Number two, soap has mixed ingredients, some of them which cause allergic reactions to patients, and some of them compromise some of the antimicrobial agents that we usually put on wounds. So let's not use soap. Use potable water. Use saline.
Mm.
Yes.
Sure. And Anonymous is asking, can venous or arterial wounds progress to gangrene?
Now, the venous patient will not have gangrene, but we have seen gangrene on patients with arterial disease. Okay. Yeah. So if the arterial disease has progressed to late stages, of course, they will come with gangrene due to perfusion problems.
How about Petronina Anyanga is asking, what is the role of ghee in wounds? That is GHE.
Now, we do not use ghee for wound management. Or maybe if you have any evidence, you can come up with some of the literature. Sometimes we read it from the internet. Is what we call anecdotal publications, which are not supported by research. Yeah, because some of the patients, I've gone to Malaysia and I've had a presentation from one of the participants who said that they have used banana leaves in the yogurt, but there's no research because if there are products which use yogurt and banana leaves, then the manufacturers will actually be working 24 hours to produce them. So let's use the products which are available in our market. Okay, so in our Kenyan market, we have many foams, plain and antimicrobial foams. We have gelling fibers, and one of the best is actually, and I'm not marketing for Convatec, but Convatec has won here is Aquacel. We have two dressings in the market. We have mitigated honey and many other nice products with nanocrystalline silver, which are available in our market. So let's not use some of these products that will give us problems.
Okay. There's Anonymous who is saying, kindly remind us how to measure our leg ankle pressures.
Ankle bronchial pressure index.
Yeah.
So I don't know whether we will have time to discuss that. Now, let me give you my number. You can call me sometime, and then I'll take you through that. Because if we go back to discussing that, we will not finish this and a lot of time. So my number is 0722 272399 0722 272399. If you have a question that possibly I've not addressed in this forum, you can call me sometime and we will discuss that. Yeah.
Remind us your online learning platform.
Okay, I'm on TikTok at Rengera Woods. Rengera is RINGERA. So I have an account there and I've posted lessons. You can go follow and read and listen to some of these lessons. I've covered wound assessment, I've covered dressing materials, I've covered negative pressure therapy. I've also covered a bit of ostomy management there. You can go through that and listen. They are very good lessons that will help you in your management.
There's a nice one here from Muritu Mbogo is asking, please comment on mafuta ya bunduki.
No. No, there's no role for mafuta ya bunduki in wound management. Yeah, there's no role. Let's forget that, Kapisa. Yeah, let's use acceptable products. Yes.
Would you comment on our KNH School of Nursing, wound stoma incontinence?
Okay, that's very good. Now we have a training at the KNH. This training is not for nurses. It is not for nurses. It is for clinical staff because we have trained even doctors from East African countries. Okay, with several the class which is finishing now actually has clinical officers. So it is not for it's not a nursing program. It is for clinical staff who have a passion for wound management, who have a passion for stomach care. Now, remember, those two specialties and continence management are not known in Kenya. That is where we have problems with the food and ostomy care in our country. Now, initially, people used to go to South Africa for 2 weeks. The others used to go to Europe for 2 weeks. Now, you do not need to go to Europe and South Africa for 2 weeks. Come to Nairobi, Kenyatta National Hospital School of Nursing for 3 good months. Nobody will give you that. Very, very cheap training. Surprisingly, it is only 40,000 shillings. Can you imagine that? And you go out with a good certificate. Even if you want to go out of the country, it is a recognized certificate. The intakes are March. Okay, we have a March class, we have a July class, and we have a class towards the end of the year, like I think it's November, yes. Yeah, so come to us, call us, go to the hospital website and apply.
Sure. I think I think there's gap in management of wound.
Yes.
I was looking at some of the questions. I might not be able to read all of them because of time, but this one, would you kindly answer this? What about doxycycline on wounds?
Now, we are now moving away from our old school management because of the problems that we're experiencing in wood management. Okay, we are moving away from GV. We are moving away from grabacin powders. Okay, which completely desiccates our wood patients because we used to think that the more desiccated our wood bed is, the quicker the healing, which is not true. Yeah, because most of the dressings which are coming nowadays are coming dressings that favor what we call moist wood healing. Yeah, so any product that will compromise that, then it's not a very good product. The other thing is that we're moving away from some products like vinegar, which is a cytotoxic agent for management of pseudomonas infections, because we know pseudomonas infections are biofilm problems, and I believe I'll be able to get time to speak about biofilm, which is also a very, very important topic. And if you apply that on your wood, of course, you will interfere with your wood healing trajectory and cripple your wood in the inflammatory phase of healing. Yeah, so doxycycline and these other products have been seen to cripple granulation and cause other problems, and they will not help you. So what we do here, okay, I think we did a lesson on we did a presentation on dressing materials, which I don't know whether our participant was able to listen. We may possibly repeat this presentation sometime so that then we can go through the current dressing materials which we have in our wood care market and how they work and why you would choose one and not the other. I think there's need for that. So then we move away from some of these products that participants are using.
And in KNH, where do I seek wound care services from?
Okay, that's a good question. If you come to Kenya National Hospital, we will go to clinic number 24. Number 24, they're inside that clinic. Number 24 is a big clinic with many, many services, but inside the clinic, there's a specialized wound care clinic. It caters for patients with wound-related problems and ostomy problems and continence problems, and that is where you get your help from.
I'm sure. The last question is, when is the next intake at KNH School of Nursing?
July this year.
July
this year.
All right.
Yes.
And
we're waiting for you guys to apply.
All right. I think those are the many questions we had. However, there are so many compliments we are getting.
Yeah.
Nice presentation. They're actually asking for this presentation. This presentation will be uploaded on KNH website. They're always there, all the presentations that have been done.
Absolutely.
Thank you, participants, for the many love emojis, for the thumbs up.
Thank you, guys.
Appreciate the nice presentation. We need to do it again and again. So there being no other comment, remember for nursing participants, you'll get the code shortly. Frank, our colleague who is at Nursing Standards Office, is waiting to disseminate the code immediately we log off from this webinar. So just another reminder, remember we are looking for many nursing series. Let's look at our nursing care, we manage patients, interesting cases you have. Just come to Nursing Standard, you'll be slotted an opportunity to present and even to disseminate your research findings. Thank you, our participants, and have a good evening. And again, thank you so much, our Ringera. We really appreciate your inputs. And for the much you have done for KNH, including starting our own care clinic at number 24, and also being the pioneer for our own care course at our School of Nursing. Thank you so much and have a good afternoon.